colleagues. Welcome to the 5th annual OncoAlert Colloquium, a comprehensive review of the year's top scientific advancements organized by Tumor Group. The colloquium is made possible thanks to our partners at the European Society of Gynecological Oncology, the European Society of Surgical Oncology, the Multidisciplinary Association of Supportive Care in Cancer, and the International Society of Geriatric Oncology. We're also grateful for the tremendous collaboration from the Advanced Prostate Cancer Consensus Conference, ABC Global Alliance in Breast Cancer, the Belgian Society of Medical Oncology, KidneyCan, the GUARD Consortium, and our friends at GUcast. We would like to thank Pfizer and Roche for partly sponsoring this year's colloquium, and we would like to remind you that all presentations that you will see have been made independently by presenters with no industry influence on topics or content. The colloquium is divided into 7 days. Day 1, GU Oncology. Day 2, Lung Cancer and Supportive Care. Day 3, Breast Cancer. Day 4, GI Oncology. Day 5, Gynecological Cancers. Day 6, Hematology, Sarcoma, Lymphoma, and Geriatric Oncology. And Day 7, How I Treat Cancer When Facing Limited Resources. Today we cover our final session of How I Treat Cancer When I Have Limited Resources. A pleasure to introduce today's speakers. Dr. Rogelio Velasco, covering lung cancer and representing the Philippines. Dr. Jose Fernando Prado Moura, covering breast cancer and representing Brazil. Dr. Natalia Gandur, covering GU malignancies and representing Argentina. Dr. Noha Fouad Mohamed Rashad, covering GI cancers and representing Egypt. We hope you enjoy the 7th day of the colloquium, and now without further ado, Dr. Velasco.
A pleasant morning to our esteemed participants and faculty. I am deeply honored and grateful to OncoAlert and the organizers of the OncoAlert Colloquium for the kind invitation to deliver a lecture on a topic that is dear to me, the management of lung cancer in a resource-limited country like the Philippines. I am Dr. Rogelio Velasco Jr., a medical oncologist from the Lung Center of the Philippines. Here are my disclosures. For this lecture, I will discuss the burden of lung cancer in Asia and the Philippines, the general approach and the management of lung cancer in resource-limited settings, and the treatment of early-stage, unresectable, and metastatic disease. In the interest of time, we will be zeroing in on non-small cell lung cancer. We begin by discussing the burden of lung cancer in the Philippines. Lung cancer was the most frequently diagnosed cancer in 2022, with around 2.5 million new cases, followed by cancers of the female breast, colorectum, prostate, and stomach. Lung cancer was also the leading cause of cancer deaths, with an estimated 1.8 million deaths noted, followed by colorectal, liver, and the female breast cancers. The burden of disease remains high, especially in Asia, where there is a high prevalence of EGFR mutations. The incidence of lung cancer among people who never smoked in Asia is higher compared with their Western counterparts. Moreover, Asian women with lung cancers are more common in never smokers compared with their ever smoker counterparts. Locally, lung cancer is the second most commonly diagnosed malignancy in 2022 after breast cancer, with more than 23,000 new cases registered, and the leading cause of cancer-related mortality with over 20,000 recorded deaths on the same year. Although major advancements in the past decades have significantly improved the treatment landscape, the 5-year prevalence of lung cancer across all ages per 100,000 population was still high. At the Lung Center of the Philippines, the nation's specialty center in lung diseases, 3,969 cases of lung cancer were diagnosed between 2009 to 2017, the majority of which were males and more than 60 years old. Around 4% were less than 39 years of age. The majority were current and former smokers, while almost 3/4 were diagnosed late in the course with stage 4 disease. Notably, only 14% were early stage 1 to 2 disease. To contextualize this lecture, let me give you an overview of the healthcare system in the Philippines. Although 48.3% have an insurance covered by PhilHealth, almost half have no insurance. In addition, there is also out-of-pocket expenditure, specifically among oncologic drugs not included in the formulary. We now discuss the unique biology of lung cancer in Asia. Lung cancer has traditionally been classified by histology. However, a greater understanding of disease biology and the identification of oncogenic driver alterations has dramatically altered the therapeutic landscape. Asia has a diverse lung cancer profile with rates of targetable mutations, as shown in the outer circle on the right, which are very high. A substantial proportion of patients with lung cancer in Southeast Asia are never smokers, and adenocarcinoma is the common histopathologic subtype found in approximately a third of the patients. There is a high rate of EGFR mutations, with 52.3% of Filipino lung cancer patients harboring this mutation. The general approach to lung cancer management begins with diagnosis, followed by molecular testing and treatment. However, as we will discuss in the latter part of the lecture, several barriers exist in the pathway. Lung cancer classification has evolved from a single disease entity to a disease with histological and molecular subtyping. We now move forward to early stage lung cancer and the use of adjuvant chemotherapy. The most frequently used treatment paradigm for medically fit patients with early stage NSCLC has been curative intent surgery, followed by adjuvant post-operative platinum-based chemotherapy. The International Adjuvant Lung Cancer Trial Collaborative Group published a seminal meta-analysis in 2004 showing a survival benefit of adjuvant cisplatin-based chemotherapy in patients with completely resected non-small cell lung cancer. Individual patient data were collected and pooled from the 5 largest trials of cisplatin-based chemotherapy in completely resected patients that were conducted after the 1995 NSCLC meta-analysis also show that post-operative cisplatin-based chemotherapy significantly improves survival in patients with NSCLC with a hazard ratio of 0.89 for death, corresponding to an absolute survival benefit of 5.4% at 5 years in agreement with the 1995 meta-analysis. In newer data, most platinum doublets perform similarly, including the use of taxanes and pemetrexed. Contextualizing these drugs in the Philippines, etoposide, gemcitabine, docetaxel are reimbursed by the government for some patients. On the other hand, vinorelbine and pemetrexed are obtained through out-of-pocket spending among our patients. Clearly, there is an unmet need in early lung cancer treatment. New treatment, including immunotherapy, have thus been shown to improve treatment outcomes for our early-stage lung cancer patients. Results from several trials evaluating neoadjuvant and perioperative immune checkpoint inhibitor-based therapies revealed significant benefit of these approaches compared with neoadjuvant chemotherapy alone. Checkmate 816 investigated the use of neoadjuvant chemoimmunotherapy. Empower 010 and Keynote 091 evaluated the use of adjuvant immunotherapy, while AEGEAN, Keynote 671, Checkmate 770, Rationale 315, and NeoTorch investigated the use of perioperative chemoimmunotherapy. Empower 10 and Keynote 91 investigated the use of adjuvant immunotherapy after surgery. Empower 10 evaluated adjuvant atezolizumab versus best supportive care after adjuvant platinum-based chemotherapy in these patients. Atezolizumab significantly improved disease-free survival versus best supportive care after resection and adjuvant chemotherapy in PD-L1 positive stage 2 to 3A NSCLC and appears to extend overall survival versus best supportive care post-resection and adjuvant chemotherapy and PD-L1 tumor cells more than or equal to 50%, stage 2 to 3A NSCLC. Although OS was immature, a positive trend favoring atezolizumab that was greatest in the PD-L1 tumor cells more than or equal to 50%, stage 2 to 3A group. Pembrolizumab is a standard of care for advanced non-small cell lung cancer. Keynote 091 assessed pembrolizumab as adjuvant therapy for completely resected stage 1B to 3A NSCLC. Adjuvant pembrolizumab provided a statistically significant, clinically meaningful disease-free survival improvement following complete resection and when indicated adjuvant chemotherapy in patients with stage 1B, T stage more than or equal to 4 centimeters to 3A NSCLC, regardless of PD-L1 expression. In early phase trials, nivolumab-based neoadjuvant regimens have shown promising clinical activity. However, data from phase 3 trials are needed to confirm these findings. Checkmate 816 addressed this clinical question. In this open-label phase 3 trial, patients with stage 1B to 3A resectable non-small cell lung cancer were randomized to receive nivolumab plus platinum-based chemotherapy or platinum-based chemotherapy alone followed by resection. In patients with resectable NSCLC, neoadjuvant nivolumab plus chemo resulted in significantly longer event-free survival and a higher percentage of patients with a pathological complete response than chemotherapy alone. We now move forward to the perioperative use of chemoimmunotherapy. Keynote 671 was a randomized double-blind phase 3 trial to evaluate perioperative pembrolizumab in patients with early-stage NSCLC. Participants with resectable stage 2, 3A, or 3B and 2-stage NSCLC were assigned in a 1:1 ratio to receive neoadjuvant pembrolizumab or placebo once every 3 weeks, each of which was given with cisplatin-based chemotherapy for 4 cycles, followed by surgery and adjuvant pembrolizumab or placebo once every 3 weeks for up to 13 cycles. Among patients with resectable early-stage NSCLC, neoadjuvant pembrolizumab plus chemotherapy followed by resection and adjuvant pembrolizumab significantly improved event-free survival, major pathologic response, and pathologic complete response as compared with neoadjuvant chemotherapy alone followed by surgery. Overall survival did not differ significantly between the groups in this analysis. Contextualizing the use of immunotherapy in operable NSCLC in the Philippines, immunotherapy is not reimbursed by the government in the Philippines, precluding their widespread use. Access programs from pharmaceutical partners facilitate their use, but still pose financial toxicity among the common Filipinos. There is also limited uptake on the use of these drugs in the perioperative and preoperative space due to limited awareness on their use, especially in the surgical field. In resource-limited areas like the Philippines, we usually use upfront surgery and adjuvant chemotherapy for EGFR and ALK wild-type patients, but we also consider clinical trials when available in our setting. The use of targeted agents in early lung cancer has also been investigated. Post-operative adjuvant cisplatin-based chemotherapy is recommended for patients with completely resected stage 2 to 3A disease and subject to post-operative evaluation in selected patients, stage 1B disease. However, this therapy is associated with a 5% decrease in the risk of death. The ALINA and ADORA trial investigated the use of adjuvant use of TKIs to address this unmet need. The ADORA trial was a double-blind phase 3 trial in which patients with completely resected EGFR mutant positive NSCLC were randomized to either receive osimertinib or placebo for 3 years. Adjuvant osimertinib provided a significant overall survival benefit among patients with completely resected EGFR mutated stage 1B to 3A NSCLC. ALINA was a global phase 3 open-label trial in which patients with completely resected ALK-positive NSCLC of stage 1B, tumor size more than equal to 4 centimeters, stage 2 or 3A, were randomly assigned in a 1:1 ratio to receive oral alectinib for 2 years or intravenous platinum-based therapy for 4 cycles. Among patients with resected ALK-positive NSCLC stage 1B, 2 or 3A, adjuvant alectinib significantly improved disease-free survival as compared with platinum-based chemotherapy alone. Among those with inoperable stage 3 NSCLC, concurrent administration of chemotherapy and radiation is recommended for patients with good performance status. Most drugs are included in the national formulary, including cisplatin, carboplatin, plus either etoposide or paclitaxel. As alluded to earlier, pemetrexed is mostly out of pocket, unfortunately. Most patients with locally advanced unresectable non-small cell lung cancer have disease progression despite definitive chemoradiotherapy. Pacific compared durvalumab as consolidation therapy with placebo in patients with stage 3 NSCLC who did not have disease progression after 2 or more cycles of platinum-based chemoradiotherapy. Durvalumab therapy resulted in significantly longer overall survival than placebo. How do we contextualize the use of adjuvant targeted therapy in operable or inoperable NSCLC in the Philippines? Unfortunately, osimertinib or alectinib is not reimbursed by the Philippine government health system. Thus, most of these drugs, when given to our patients, are out of pocket. Concurrent chemoradiotherapy for inoperable stage 3 or with consolidation out-of-pocket durvalumab is considered in some patients. We also consider clinical trials when available to our patients. Let us now press on and discuss oncogene-addicted metastatic non-small cell lung cancer. This slide describes the general pathway in metastatic lung cancer management. Histologic assessment, molecular assessment, and PD-L1 determination is central in the management of these patients. Among the breakthroughs in therapeutic approaches, advances in targeted therapy have brought the most successful outcomes in non-small cell lung cancer treatment. Lung cancer has traditionally been classified by histology. However, a greater understanding of disease biology and the identification of oncogenic driver alterations has dramatically altered the therapeutic landscape. The ESMO guidelines outline 11 driver genes which are targetable. Allow me to walk you through some of these agents. Patients with non-small cell lung cancer whose tumors harbor EGFR mutations frequently derive significant clinical benefit from EGFR tyrosine kinase inhibitor, including the first-generation TKIs gefitinib or erlotinib, second-generation afatinib and dacomitinib, and the third-generation osimertinib and lazertinib. Among patients with previously untreated advanced NSCLC with EGFR mutation, those who received osimertinib had longer overall survival than those who received a comparator EGFR based on the FLORA trial. First-line treatment with osimertinib plus chemotherapy led to a significantly longer progression-free survival than osimertinib monotherapy among patients with EGFR-mutated advanced NSCLC in the FLORA-2 trial. Amivantamab, via its novel mechanism of action, yielded robust and durable responses with tolerable safety in patients with EGFR exon 20 insertion mutations after progression on platinum-based chemotherapy. The use of amivantamab chemo resulted in superior efficacy as compared with chemotherapy alone as first-line treatment of patients with advanced NSCLC with EGFR exon 20 insertions. During the last decade, clinical outcomes of ALK-rearranged advanced NSCLC patients significantly improved due to the development of small molecules that specifically inhibit ALK, such as lorlatinib, brigatinib, and alectinib. The 5-year overall survival in these trials was generally more than 60%. In a large cohort with extended follow-up, selpercatinib continued to demonstrate durable and robust responses, including intracranial activity in previously treated and treatment-naive patients with RET fusion-positive NSCLC. Pralsetinib treatment produced robust efficacy and was generally well-tolerated in treatment-naive patients with advanced RET fusion-positive NSCLC. Trastuzumab deruxtecan showed durable anti-cancer activity in patients with previously treated HER2-mutant non-small cell lung cancer. Sotorasib therapy led to a durable clinical benefit without new safety signals in patients with previously treated KRAS G12C mutated non-small cell lung cancer. In patients with previously treated KRAS G12C mutated non-small cell lung cancer, adagrasib showed clinical efficacy without new safety signals. Sotorasib significantly increased progression-free survival and had a more favorable safety profile compared with docetaxel in patients with advanced NSCLC with KRAS G12C mutation and who had been previously treated with other anti-cancer drugs. How then do we contextualize the use of targeted therapy in metastatic non-small cell lung cancer in the Philippines with actionable mutations? We have two major barriers in terms of targeted treatment in the Philippines. The first one is diagnostic or biomarker testing. The second one is availability of the drugs. Although we all know that the standard of care in lung cancer is testing for EGFR, HER2, MET exon 14 alterations, ALK, cross, MET, and NTRK gene fusions, KRAS G12C mutations. In our country, EGFR is mostly done through PCR with assistance from pharmaceutical companies. ALK is done through IHC testing. ROS1 is likewise done through IHC testing. We also have a lung cancer panel package which covers a basic mutation through the AMY gene panel. Foundation 1 is available but is costly in our setting. Several emerging NGS panels, although not yet regulated, are available at a much lower price, mostly from India, Taiwan, or Singapore, where we actually send the samples of our patients for a more affordable next-generation sequencing, but with a fewer genes compared to the Foundation 1 NGS. EGFR TKIs are widely used in the Philippines due to the high rates of these EGFR mutations. However, they are not reimbursed and are mostly out of pocket. First and second generation EGFR TKIs have generic counterparts, mostly from India or Taiwan, at reduced cost, and these are usually preferred by the majority of our patients who actually belong to the resource-limited strata of our society. Amivantamab is available but not reimbursed and is mostly out of pocket. Likewise, osimertinib is also not reimbursed, and there is no generic version available in the Philippines. ALK fusion inhibitors, alectinib, brigatinib, and lorlatinib, including TDXD, are also available but are not reimbursed. Thus, these are mostly out of pocket. However, there are access programs available offered by the pharmaceutical companies to reduce their costs. Unfortunately, even with reduced costs, the common Filipino still has major problems availing these drugs. Limited treatment options available beyond the common EGFR and ALK inhibitors in the Philippines. Other targeted drugs are also not available and may be shipped from nearby countries like Singapore for those patients who can afford these agents. Thus, chemotherapy or immunotherapy for some mutations still remain the backbone of treatment for these patients. There are limited clinical trials in the Philippines for these rare mutations as well, which is also a major barrier in our country. Moving forward, I will discuss in brief the management of non-oncogene-addicted non-small cell lung cancer stage 4. Again, this is a general approach to non-small cell lung cancer stage 4. The ESMO guidelines recommend an individualized approach based on performance status and PD-L1 expression in determining the best fit regimen for our patients based on the landmark trials Keynote 189, Empower 150, Checkmate 9LA, and Empower 130 among patients with non-squamous non-small cell lung cancer. Among patients with squamous non-small cell lung cancer, molecular testing is still advised among patients who are never or former light smokers, less than 15 pack-year smokers, long-time ex-smokers, or age less than 50 years old. The ESMO guidelines likewise recommend triaging based on performance status and PD-L1 expression to determine the most suitable regimen. Despite the tremendous strides in the landscape of NSCLC treatment, several barriers exist, especially in LMICs like the Philippines, including unmet needs in biomarker testing and treatment. Barriers to cancer diagnosis include limited capability and expertise in the interventional and pathologic services, travel burden, lack of awareness, and lack of reimbursement. Unmet needs in biomarker testing include limited capability and expertise in NGS, limited number and location of molecular testing facilities, lack of awareness, knowledge, and lack of reimbursement. LMICs likewise face challenges in cancer treatment such as limited availability of drugs not enlisted in the formulary, regulatory delay, travel burden, lack of knowledge or awareness, and the high cost and lack of reimbursement. The cost of immune checkpoint inhibitors limit their accessibility to a small number of patients with cancer in low to middle income countries. Early phase studies have shown target inhibition in high activity at doses lower than those registered and evaluated in clinical trial. How then do we address the challenges in non-small cell lung cancer treatment in lower middle income countries? As alluded to earlier, there is financial toxicity on the use of immunotherapy, especially in lower middle income countries. I looked into some studies studying cost-effective dosing of immunotherapy in resource-limited countries like India, Korea, which can be applied in the Philippines. Pembrolizumab has received FDA approval for the treatment of lung cancer at a fixed dose of 200 milligrams every 3 weeks. However, doses above 2 milligrams per kilogram show a lack of benefit, calling for further evaluation in Asian population. This study aimed to assess the efficacy of a lower dose, fixed dose of 100 milligrams, which is closer to 2 milligrams per kilogram weight-based done in an average-sized Asian patient. This study was conducted in Singapore. This retrospective observational study demonstrates the efficacy of a lower dose of pembrolizumab, 100 milligrams every 3 weeks, compared with standard dose pembrolizumab. The results also confirm the clinical activity of pembrolizumab at a lower dose than 2 milligrams per kilogram every 3 weeks, which could provide considerable cost savings to patients and the health system reduction in cost. A randomized trial should be done to investigate a lower dose of pembrolizumab. Moving to another immunotherapy, which is nivolumab. This study evaluated the efficacy of low-dose nivolumab as an alternative to the financial toxicity of standard-dose nivolumab in the treatment of NSCLC. This was done in Korea. Among patients with non-small cell lung cancer treated with nivolumab as a routine practice at 2 tertiary hospitals in Korea, patients who received low-dose nivolumab, which is 20 or 100 milligrams every 3 weeks, showed similar survival outcomes and response rates to those who received standard-dose nivolumab. Low-dose nivolumab can be effective in NSCLC and is worth considering as an alternative option to reduce financial toxicity, especially in lower middle-income countries like the Philippines. The efficacy of low-dose nivolumab requires further randomized trials. There are other opportunities to improve healthcare in the Philippines, and this is in collaboration with other international organizations, including ESMO, which they produce the ESMO Pan-Asian Adapted ESMO Clinical Practice Guidelines. Tailoring the ESMO Clinical Practice Guidelines to the local context results in a resource-efficient, valuable Pan-Asian Adapted Guidelines that can be used by health professionals and patients to harmonize optimal evidence-based practice across Asia, focusing on ethnic differences and potential approach to regulatory authorities. There are also barriers to research in lower middle-income countries. Improvement of research infrastructure, optimizing research regulatory processes, increasing research funding, and addressing sociocultural challenges are necessary to capacitate lower middle-income countries in conducting research. There are several networking opportunities among young oncologists in Asia. This is an example organized by the Korean Society of Medical Oncology. This was a networking session among young oncologists in Asia, and was very fortunate to be part of this endeavor, in which we identified key issues and championing possible solutions to pressing problems in cancer care in lower middle income countries in Asia. There are also several groups which champion thoracic oncology care in Asia. The Asian Thoracic Oncology Research Group was formed in 2016 with a vision to be the central coordinating platform for multi-center clinical trials and translational research in Asia. Last weekend, I was fortunate to attend a seminar organized by the Asian Thoracic Oncology Research Group in Malaysia. Facing challenges and creating opportunities in the Philippines. Our key challenges include the availability of drugs, including targeted drugs and immunotherapy, and of course, the cost of these drugs, and most of these are actually out of pocket. And GS is not reimbursed and is mostly out of pocket, similar to the drugs. There are also limited clinical trials available in our country, and phase 3 trials are mostly available in urban areas. And as you all know, the Philippines is composed of around 7,107 islands, and these trials are actually concentrated within the urbanized areas. Thus, there is low uptake of these clinical trials and also even cancer screening in areas which have limited education on the importance of lung cancer screening and even screening for other malignancies. Now, how do we create opportunities from these challenges? Opportunities include improving access to programs to cut down cost of drugs, implementing the National Integrated Cancer Care Act, upscaling programs focusing on lung cancer screening, developing local lung cancer registries. It is also prudent to improve research infrastructure and increase clinical trials available in our country. We must also leverage on the rich and diverse lung cancer biology in Asians as opportunities for research. In specialty cancer centers, tumor boards and multi-specialty care must be established to improve lung cancer outcomes. In the regulatory space, essential drugs should be approved at a faster pace. Finally, cancer prevention measures should also be strengthened. Finally, the burden of disease of lung cancer remains high, especially in Asia. Identification of oncogenic driver alterations has dramatically altered the therapeutic landscape. There is a high recurrence rate after resection for localized lung cancer. Adjuvant chemotherapy is recommended for stage 1B with high-risk features to stage 3 with 5% survival benefit. Neoadjuvant or perioperative immune checkpoint inhibitor plus chemotherapy improves PCR and EFS compared to chemotherapy alone in patients with resectable stage 2 to 3 EGFR ALK-negative NSCLC. Adjuvant TKI prolongs survival among patients with EGFR mutations or ALK translocations. Among lower middle income countries like the Philippines, several barriers exist in lung cancer diagnosis and treatment. Addressing these barriers to testing and treatment is crucial to optimize cancer care in lower middle income countries like the Philippines. Thank you very much once again, and I'm very much honored to be part of the OncoAlert Colloquium.
Hello, everyone. It's a pleasure to me to be able to share a little of my work here in Brazil in treatment of breast cancer. My name is José Fernando Moura. Brazil is a country of continental dimension, and I currently live in Recife, state of Pernambuco, known for its beautiful beach and some historical sites, such as First Synagogue in Americas. I work in two institutions, Real Hospital Português, private healthcare, and MIP, public healthcare, conducting clinical trials in patients with breast and lung cancer. I talk about some topics in this presentation. Breast cancer statistics in Brazil, access to screen diagnosis journey, 2 words to treat, challenge in public and private healthcare, clinical trials, a bridge to equity, and conclusions. Breast cancer statistics. Approximately 80% of Brazilian population has public health care as their only form of access to health. According to data from the National Cancer Institute. Around 74,000 new cases of breast cancer are expected annually. Retrospective data from Amazon study shows that about 40% of these patients are younger than 50 years. Screen diagnosis journey. There are different screen recommendations in Brazil. The National Cancer Institute recommends starting at age 50, while several medical societies recommend starting mammography at age 40. Despite this recommendation, most cases are diagnosed at stage 2 and 3, and about 1/3 were identified by screen. Younger were more symptomatic at the diagnosis and more frequently with stage 3, T3, T4, grade 3, HER2 positive, luminal B, and triple-negative subtypes. Considering public healthcare, in Brazil, there is a 60-day law to start treatment after confirmation of diagnosis. However, there are barriers prior to confirmation of the diagnosis. In many cases, takes long time for diagnosis to be made, and there are still long queues for surgery and radiotherapy. About 46 days, how shows in Amazon study. Considering during in private healthcare, maximum of 2 weeks to get the diagnosis and access to the team. In private healthcare system, there are slight delays related to the authorization of treatment bureaucracy, but are not quick. 2 words to treat. Challenging in public and healthcare. Public adjuvant setting is different in terms of access to therapy. Chemotherapy include capecitabine, endocrine therapy, and trastuzumab are okay. On the other hand, new target therapy and cyclin inhibitor, ADCs, immune therapy is not accessible for the population. On the other hand, private healthcare, here, most of the current treatments are evaluated. Delays of up to 1 year after FDA approval are common for implementation in private healthcare, whereas this delay can be more than a decade or never happen in public system. In metastatic scenario, it's not different. Equity in public and healthcare. There are few treatment options in public healthcare. A lot of options in private healthcare. Other important topics such germline tax access, radiosurgery, reconstruction, risk-reducing surgery, and palliative care shows different access between public and private healthcare. Palliative care is carried out by oncologist himself in most cases, in both public and private healthcare. Clinical trials, a bridge to equity. Why clinical trials matters in low-middle income? Diversity, access, recruitment, and cost are topics here. Low-middle income countries represents less than 10% population clinical trials. Low-middle income countries have larger population. Gold standards in majority of low-middle income countries not available. Control arms offers better choice than majority therapies available here. Recruitment. Low-middle income countries can improve recruitment in competitive trial settings that are common in the days nowadays. Reducing cost matters. Smart clinical trials can reduce costs for all chains, pharma, private, and public healthcare. So clinical trials can cut the gap, link the borders in breast cancer in low-middle income countries. Recife Snow was a city with a large number of bridges. In conclusion, patients living in low-middle income countries suffer larger gaps during breast cancer journey, particularly in public healthcare. Disparities, important barriers to access early diagnosis of therapy, equity, larger gaps in therapeutic approach. Clinical search has a challenging and opportunities for the system. So we need to consider burnout. Please pay attention for the team. Where there is disparity, there is a great risk of burnout. Thank you for my team in public and healthcare. Thank you for my family, and thank you for all colleagues and friends in OncoAlert in this OncoAlert Colloquium. No one is better than all of us together. See you in person at ASCO. Thank you.
Good evening, everyone. I'm Dr. Noha Rashad, lecturer of medical oncology from Egypt, Suez University. Thanks to OncoAlert faculty for inviting me to give this talk about how I treat GI cancers with limited resources, taking Egypt as an example of a low middle income country. These are my disclosures. During the next few minutes, I'm going through these points regarding cancer statistics in Egypt. How do we provide cancer care, taking 3 examples of different cancers management, HCC, colorectal cancer, and neuroendocrine tumors. Egypt is one of the largest countries in Africa, inhabited by more than 100 million citizens. As we can see here, and according to Global Cancer Statistics, liver cancer ranks first as the most commonly diagnosed cancer in both sexes. It is the first one in males and the second after breast in females. This shift has been seen during the last 2 decades. Before that, bladder cancer was the first and most commonly diagnosed cancer in Egypt. This shift was seen because of the eradication of schistosomiasis, which was a parasitic infection involved in the etiology of squamous cell carcinoma of bladder cancer. Currently, bladder cancer is not the first anymore, and also the shift was seen in the pathology, as most of bladder carcinomas we see today are of transitional cell carcinoma variant. Regarding other GIT malignancies, colorectal cancer ranks 7th as the most commonly diagnosed cancer in Egypt, and we can see also that pancreatic cancer and gastric carcinoma ranks as the 10th and 11th places. Oncology care in Egypt is usually provided by multiple providers: Ministry of Health through different cancer centers, university hospitals, which is around, it's more than 20 university hospitals all over Egypt. Most of them are having a comprehensive cancer units. non-governmental organizations which can offer care on more than one level, either in the form of compassionate use of drugs or sponsorship of drugs that are not covered by insurance, or in a form of a large comprehensive centers like the Shifa Orman Comprehensive Cancer Hospital in south of Egypt. We also have military and police oncology units in the private sector. Egyptian patients have an access to advanced imaging and diagnostic tools. Also, advanced surgeries are performed, but not in everywhere. It is mainly in large and specialized cancer centers. Chemotherapy is usually funded by the governmental and different insurance agencies. However, targeted therapies and immunotherapies are not available in the governmental sector. Usually, it is available at the private sector as an out-of-pocket treatment or sponsored by different NGOs. Taking HCC management in Egypt as a unique situation for management of a cancer in a developing country. In 2007, Egypt was one of the countries with the highest prevalence of hepatitis C virus, with genotype 4 responsible for around 92% of the infections, followed by genotype 1. This caused the shift we have seen in here and the rising incidence of liver cancer, also liver cancer-related mortality. Looking at the treatment algorithm of treatment of HCC based on the BCLC, we can say that the radiofrequency ablation and transarterial chemoembolization are available all over Egypt in many centers, either in the governmental or the private sector. Also, hepatic resection and liver transplantation are available in more than 16 centers all over Egypt. However, access to SBRT and SIRT is not that common, available or 2 or 3 centers. Coming to the systemic treatment and with the evolution we have seen during the last few years in systemic management of HCC, starting with TKIs in the form of sorafenib, lenvatinib, followed by the era of immunotherapy we are seeing these days. This is the quite challenging situation because all of these agents are expensive with limited access in many institutions. Also, the other challenge is the data we have seen regarding the efficacy of sorafenib. This was one of many real-world data coming from different centers in Egypt, denoting that the overall survival seen with sorafenib in Egyptian population is shorter than that reported in clinical trials, with an overall survival of 5 months, which is shorter than that even reported in the Asia-Pacific study. This was attributed maybe to an occult HPV infection, maybe because of the involvement of pathogenesis of genotype 4 HCV causing a different pathogenesis in which sorafenib is not the optimal agent. However, this was not enough to exclude sorafenib from our healthcare system that's offered to patients. However, the treatment of sorafenib is mainly limited to patients who will benefit most, either with child A classification or those with performance status 1. During the last year, the Egyptian Society of Liver Cancer recommendations were published, and they endorsed the importance of MDT evaluation of cases for proper treatment planning, and also to build a referral system that will be work on classifying the patients and referring them to institutions where they will benefit most. Also, we have seen many advancements. One of them is a presidential initiative for treatment of liver cancer, screening and treatment. It was launched in 2018 for HCC screening, and in 2022 for treatment of hepatocellular carcinoma. It was offering screening to high-risk targeted population with cirrhosis, HCV positive patients, offering treatment within specific centers and sites all over Egypt. Till now, more than 60,000 patients in different stages of HCC were treated within this presidential initiative, and treatment options available in this initiative are very wide, including immunotherapy. So we can summarize that and say that sorafenib and lenvatinib are available in most institutions as treatment options. Atazobeva and the STRIDE protocol of Tremi-Durva are available, but in very limited sites and institutions, including those supported by the presidential initiative and very limited special institutions insurances. Another thing Egypt has done for the management of HCC on the preventive level is the screening and treatment program to eliminate hepatitis C in Egypt. It was launched in 2015. By 2018, more than 2 million HCV patients received direct antiviral agents, and also Egypt did an effort in decreasing the cost of direct acting antivirals in Egypt through local manufacturing of these agents, reducing the cost and so allowing more patients to access to these drugs. In October 2023, the WHO awarded Egypt the Golden Tier status on the basis of the elimination of hepatitis C eradication, as Egypt succeeded in eliminating the HCV virus in more than the targeted 80% of targeted population declared by the WHO. And I think we are going to see the reflection of this ambitious program on the decline of HCV cases in Egypt, of HCC cases in Egypt during the next decade, maybe. Coming to colorectal carcinoma and how we treat colorectal carcinoma. As we have seen before, colorectal cancer is the seventh most common cancer in Egypt. And also in Egypt, we have seen what is witnessed all over the world with an increase in incidence and having a very large proportion of early onset colorectal cancer. In this multi-center study, our group conducted more than 1,000 patients were included. More than 40% of patients were diagnosed below the age of 45 years old, and also females were almost equally affected as males, which is quite different than what we know with predominant male affection. Rectal tumors are significantly higher in early onset colorectal cancers, and more than 30% of our patients presented with metastatic disease. Regarding the current treatment options for management for adjuvant treatment in stage 2 and 3 colon cancer, and also for the new adjuvant treatment for rectal cancer. All these treatment options are widely available in Egypt, both on the governmental and insurance hospitals. We don't have a problem in that. However, the main challenge is in this algorithm in the management of metastatic disease. As we can see here, we have a plethora of targeted agents that are finding its place in the management of metastatic colorectal cancer, especially in the first line as well as later lines. Egyptian patients have an access to molecular testing for RAS-BRAF. It's usually sponsored by pharmaceutical companies. And in some institutions and in some sites, also patients has an access to the MSI status. However, the availability of the drug is the matter of question. And usually we face a lot of challenging questions like, shall we add biologics to first-line chemotherapy backbone, and which biologic to add? Shall we adopt maintenance strategies? What about immunotherapy, second-line treatment options? Shall we also add biologics to treatment options in second line, or in patients who received biologics, can we continue beyond progression? And what about later lines? In 2022, the resource-oriented decision-making for treatment of metastatic colorectal cancer consensus recommendations were published by the Egyptian Foundation of Medical Sciences. We had the pleasure to share in this very valuable publication. Our aim was to offer resource-oriented guidance for physicians working in Egypt how to take the decision for patients with metastatic colorectal cancer, also to reduce variability in cancer care between institutions, and also we conducted an external review for the recommendations to explore the possibility of its dissemination and adaptability by countries with similar circumstances like Egypt, mainly in Tunisia and Morocco, and also in a country with a low income country like Sudan. The recommendations were stratified into three main groups. One of them is general recommendation. It is the recommendations that could be applied regardless of the resource setting. We have the restricted resources setting. This recommendation defines the minimal level of clinical service and patient management that could be offered to patients. And for the non-restricted resources, we are talking about recommendations that could be applied regardless of the question of resources. However, we have another situation which is quite complex and different because in many institutions, it is not either all or none. We have some biologics, we have immunotherapy even in some institutions. However, it's not available to everyone. It's a limited access situation. So this puts on us a very more challenging question is how to select the proper management for these agents. According to our recommendation, NDT assessment is mandatory to classify patients into distinct groups for treatment planning, and the aim of treatment should be defined to guide treatment decision. However, we acknowledge that there was a major limitation. It is the absence of cost-effectiveness studies with no clear cut-off points defining which treatment could be of negligible benefit and which is not. So, for example, regarding the addition of anti-EGFR in fit patients with borderline resectable disease in restricted resources, we recommend the addition of anti-EGFR in patients with BRAF, RAS wild tumors, regardless of sidedness, because these patients are amenable to a very long-term overall survival and even cure in small proportion of patients. The option of folfoxiri, if access to anti-EGFR was also discussed. However, it's not justified by the panel because of the fear of the state of orange liver or the toxicity that's caused by chemotherapy that may cause resection to be of a worse outcomes compared to treatment with anti-EGFR combined with chemotherapy. And so we advised, even in restricted resources, in these patients, try to have an access to anti-EGFR. However, in non-restricted resources, the state is different. And even in right-sided tumors, BRAF mutated, the addition of anti-EGFR is recommended either to the backbone of chemotherapy doublet or triplet. For patients who are classified by the MDT as having a non-resectable disease or where resection is not a realistic goal, chemotherapy alone is the treatment options, and we are not usually going to add biologics. The question of immunotherapy is even more complicated. We discussed what's called the negative selection, or trying to exclude patients who may have a negative predictive factors or factors that are predictive of resistance to immunotherapy as patients with ascites, as we can see in here in this retrospective cohort conducted on group of patients who received immunotherapy. Patients with ascites tend to have much more worse outcome with treatment with immunotherapy. However, it's not that easy. It's not that direct question, because we have also discussed other options like adding an extra marker to the MSI, like maybe the POL1 mutant patients who may have a higher response rate, or maybe adding the tumor mutational burden. However, all these are non-conclusive markers and their role in the treatment planning is not clear. So the question of immunotherapy is still open and it's not usually added or even sponsored by many of the NGOs. I think this will change, but not in the metastatic setting. This will change most probably in rectal cancers with the more evidence accumulating regarding the benefit of immunotherapy as a new adjuvant treatment in rectal tumors. Sorry for that. What about maintenance strategies? So for maintenance strategies, even in patients who received first-line treatment with the addition of biologics, which is maybe seen in some institutions as well, and in absence of an overall survival benefit, either with bevacizumab continuation or anti-EGFR continuation, or even switch maintenance between anti-EGFR to an anti-neovascularization, like that's seen in the FIREFOUR trial, for example, we don't usually support this practice in absence of an overall survival. What about second line? We don't have a problem in the availability of FOLFOX, FOLFIRI, and the interchangeable use of these. First line, second switch to the other one in second line. There is no problem in that. However, also in absence of an overall survival benefit with the anti-EGFR, we are not supporting it in second line. Bevacizumab beyond the progression, although there is data of an improvement in the progression-free survival, we are also not supporting this practice. Switch to anti-VEGF despite evidence of limited and minimal overall survival benefit. We are also not supporting this practice in our everyday common practice, maybe in the private sector. What about later lines of treatment? And here is another challenge, because as we can see in here, we have a lot of options, many targeted agents, chemotherapeutic agents like trifluridine, tipiracil, with or without bevacizumab, and also we have the regorafenib. All these treatment options are very expensive and not usually offered by many institutions or general institutions. So what to do in this situation? The EFMS consensus panel suggested these treatment options, either with single agent irinotecan, rechallenge, or reintroduction of previously used agents in patients who showed response to this treatment. Capecitabine single agent or IROX suggested these treatment options based either on early trials before the era of targeted therapies, small phase 2 trials. This is not a very strong or expert even opinion. This is not supported by very high evidence. However, in some institutions, this might be the best options the treatment can have. In some institutions, like the NGOs, for example, which may sponsor the treatment for a specific group of patients, we need to go and dig deep in the data to find out which patient will benefit most with the treatment. For example, this exploratory analysis for the RECOURSE trial in patients who are receiving trifluridine tipiracil, this exploratory analysis identified 3 groups of patients. Patients with good prognostic characteristics, defined as those with low tumor burden, less aggressive disease, 1 or 2 metastatic sites, long duration since time of diagnosis of metastatic disease till the current time of receiving the third line or maybe beyond. Patients with poor prognostic characteristics, mainly those with a very short duration of progression, and those with a heavy metastatic disease burden. And also they identified a group of best prognostic characteristics, namely patients with no liver metastasis. We can see here that patients with best prognostic characteristics gained an overall survival of 60.4 months with treatment in third line. Patients also with good prognostic characteristics gained this benefit, longer overall survival of 9.3 months. We know the drawbacks and limitations of post-hoc analysis, of a subgroup analysis. However, sometimes this is the tool you have to select the proper patient to receive the treatment. Interestingly, sometimes access to anti-EGFR in later lines, either in patients who didn't receive it before or even patients who received it in first line, could be more realistic approach and even more affordable compared to the access to regorafenib and trifluridine tipiracil. However, this is a very limited practice, usually reserved to patients in whom we wish to have a rapid response and rapid tumor shrinkage for improvement of rapid improvement of symptomatic disease. And this is based on the data from the CRICAT and CHRONOS trials. However, these patients usually, in absence of access to circulating tumor DNA, if it is not accessible, we usually go with the clinical parameters, set and definitions defined by the CRICAT criteria, as choosing patients who had a very good response with anti-EGFR in first line if previously exposed to it, with the last anti-EGFR exposed more than 6 months. This could be a treatment option, but in a selected group of patients. Also, something like the dose escalation or giving a lower dose, which should be also supported by evidence, like the REDOSE trial, which tested the dose escalation with regorafenib, which is a very good trial, actually, because it's not only identifying patients who will tolerate the treatment, and also, on the other hand, it offers a cheaper option that may enable us to treat more patients and pick those who will not tolerate the treatment well. So, and finally, and looking at neuroendocrine tumors and how and taking a glance at how we manage a rare disease. As we all know, neuroendocrine tumors are the zebras of cancer. It is very rare, rarely suspected in Egypt, and unfortunately, we don't have much data on the incidence and prevalence of neuroendocrine tumors. Published literature is very limited, mainly case reports and case series, so we don't have enough attention to this group of or family of tumors, which is totally unlike the HCC. These are unpublished data coming from one of our institutions. A study was conducted retrospectively to study neuroendocrine tumors in the SOH hospital. We conducted this analysis from March 2018 to March 2021. A total of 68 patients with mid-gut neuroendocrine tumors were included. In this group of patients, 5-HIAA and IAA in urine was tested only in about 15% of patients. Serum chromogranin A was not tested in any patient, and also gallium dotatate capacity was the initial staging investigation performed in about 7.5% of patients, despite and also it was outsourced. It was not available institution. It's available only in about 5 or 6 institutions all over Egypt. So the take-home message of my presentation: sometimes screening and preventive measures are of a very high importance because it's mandatory to improve cancer control and also to decrease the cancer treatment costs on the long term. Proper patient selection with highly selective criteria could be a method to improve the resource allocation. HCC is a very unique situation because the national campaign of HCV eradication will minimize the cost of HCC treatment by decreasing the disease burden, and also the initiatives we have in our country currently to deal with HCC as a national concern. For colorectal cancer, the cautious interpretation of data with hyper-selection of patients may allow a subgroup of patients to have a better chance for treatment. However, it's not an easy mission because you have to dig very deeply in the evidence to identify how to take the decision based on acceptable level of evidence. And finally, neuroendocrine tumors, more action is required, and coordinated healthcare is mandatory to enable patients to enable us to manage these patients properly. Thank you for listening, and thanks to Dr. Jill Morgan for inviting me to give this talk. Thanks to OncoAlert faculty. Honored to be with you, and I think now we will move to the discussion.
Good morning, everyone. I am deeply honored to be here at the OncoAlert Colloquium 2024. First, I would like to thank the organizer for this opportunity to share my experience in treating genitourinary tumors when access to standard drugs is limited. In this presentation, I will discuss practical strategies to provide the best possible care under challenging circumstances. Thank you for being here. To set the stage, let's discuss the global barriers we encounter in treating genitourinary cancers. Let's begin by understanding the burden of genitourinary cancers in low and middle-income countries. Prostate cancer, the most common cancer in men, has high mortality here due to late-stage diagnosis and limited access to therapies. Bladder and kidney cancer present similar challenges with delayed diagnosis and inadequate access to target treatments. Meanwhile, testicular cancer, which is highly curable when detected early, often progresses in these countries due to low awareness and lack of screening programs. These inequities are reflected in GloboCan 2024 data, highlighting disproportionately high mortality rates in these countries. Now, we must consider what are the barriers driving this outcome. One of the biggest barriers is limited access to life-saving medication, such as cisplatin, which is essential for treating many genitourinary cancers. This high cost of innovative treatments like immunotherapy and targeted therapies exacerbate this issue. Additionally, healthcare infrastructure is often inadequate with a shortage of trained professionals to deliver care. However, solutions are within reach. Programs that assist patients internationally, local production of generic medications, and strengthening global partnerships to subside costs that can make a significant impact. With these strategies in mind, let's move on to discuss specific examples of practical interventions. Here, we see a summary of the main challenges in managing genitourinary cancers in these countries and potential solutions. Limited access to advanced therapies often leads to reliance on less effective alternatives. Delayed diagnosis is another issue due to low awareness and the absence of screening programs. Additionally, inadequate healthcare infrastructure and financial constraints prevent patients from accessing timely care. But if there is hope, implementing international assistance program, launching awareness campaign, investing in infrastructure and training, and developing government funding insurance schemes are key steps forward. These strategies can create meaningful changes, as we'll see in real-world examples. Local data can be a powerful tool for driving policies, changes, and improving outcomes. In Brazil, evidence on the effectiveness of intravesical mitomycin led to increased funding for bladder cancer treatments. In Peru, identifying disparities in nephrectomy access sparked advocacy for equitable surgical care. And in Colombia, universal health coverage has significantly reduced prostate cancer mortality. The charts highlight the impact of cancer registries, showing up to a 13% reduction in mortality where robust registries exist. These examples emphasize the importance of data in addressing inequities and guiding future policies. Multidisciplinary care is essential in low-middle-income countries, where resources are often limited. The process begins with a thorough clinical assessment, ensuring that all patient needs are identified. From there, we move to team discussions involving oncologists, urologists, radiologists, and pathologists to create a comprehensive plan. Treatments are then adapted to available resources, focusing on maximizing outcomes with what is accessible. Implementation is followed by close monitoring, and finally, a feedback loop ensures continuous improvement. The collaborative approach is key to overcoming challenges and improving care delivered in resource-limited settings. Genitourinary cancers show alarming trends in low STI regions. Prostate cancer remains the most diagnosed with a 22% increase, where testicular cancer has the fastest growing incidence, up by 45%. Kidney cancer is rising as well, linking to aging and obesity. Mortality trends highlights an 11.6% increase for kidney cancer, while improved management has reduced death from bladder and prostate cancer globally. Risk factors like smoking and obesity play a major role, especially for bladder and kidney cancers. Access to oncology drugs remains a global challenge with barriers ranging from high drug costs and limited price negotiation to inequities in universal health coverage. Regulatory delays and drug shortages further complicate access, particularly in resource-limited settings. On a global level, there is a need for transparent drug pricing and stronger national cancer plans. Proposed solutions include adopting evidence-based pricing models, fostering global collaboration to enhance clinical trial participation, and investing in healthcare. This map highlights key obstacles in genitourinary cancer care across different regions, such as strict reimbursement criteria, low health literacy, and limited access to multidisciplinary care. Now, let's focus on the challenges related to drug availability in low and middle-income countries. This is a critical issue that impacts cancer treatment outcomes and highlights the need for creative and practical solutions. To understand these challenges better, let's look at specific barriers and their effects. There are several barriers to accessing essential cancer drugs in low-middle-income countries. High costs make treatments like pembrolizumab unaffordable, while shortage of drugs like cisplatin delay or interrupt treatments. Issues with supply chain, such as cold chain failures, further disrupt medication availability. Lastly, a lack of trained oncologists in rural areas lower the quality of care patients receive. Together, these barriers create a significant gap in cancer care, as shown in the chart, where high cost alone account for 40% of the problem. To address these challenges, we need targeted solutions. Increasing generic drugs imports and encouraging local manufacturing can improve availability. Resource-adapted guidelines help make treatment more affordable, and training programs, including telemedicine, can expand the number of skilled specialists. Comparing drug availability in high and low-income countries shows how urgent these measures are for reducing the gap and improving patient outcomes. Collaboration is key to addressing treatment gaps. By working together across disciplines and regions, we can create strategies to the needs of these populations. Now, let's look at how evidence-based strategies can help us adapt treatment in these settings. In low-resource settings, we often need to rely on older yet effective drugs. For example, cisplatin remains affordable and highly effective for bladder cancer. Similarly, mitomycin is crucial for non-muscle invasive bladder cancer. Radiation therapy plays a vital role in prostate and bladder cancer, especially when systemic therapies are unavailable. Surgical intervention like radical prostatectomy or TURBT are also essential in diagnosis and management. Finally, multidisciplinary teams helps integrate local expertise with international guidelines, ensuring comprehensive care for patients. Collaboration works best when we align clinical guidelines with local resources. Simplified protocols such as affordable hormonal therapy for prostate cancer are examples of this. Training programs using telemedicine like Project ECHO help build capacity by connecting experts with remote providers. Research and data collection, including cancer registry, inform policies and improve outcomes. For instance, a registry in sub-Saharan Africa enhanced prostate cancer care by adapting NCCN guidelines. These efforts show how shared knowledge and collaboration can overcome barriers in cancer care. Now let's explore how practical strategies can be applied in real-world situations where resources are limited. This case study will highlight key local solutions and their impact on improving access to cancer care. In resource-limited settings, local innovations play a vital role. For example, Argentina's local production of BCG reduces dependency on global supply, ensuring better availability for bladder cancer patients. Regional networks help develop tailored guidelines for genitourinary cancers. Educational initiatives, including training programs and community outreach, improve professional skills and raise awareness about early diagnosis. However, challenges remain, such as unequal access to diagnostic and therapeutic tools. Regional collaboration is essential to ensure equitable healthcare delivered for all. In resource-limited settings, it is crucial to maximize available strategies. Surgery remains a cornerstone with cytoreductive nephrectomy benefiting patients with low metastatic burden and good performance status. For palliative purposes, radiotherapy is effective, especially for symptomatic bone metastasis. Where medications like BCG are scarce, intravesical alternatives such as mitomycin C can be used, though with lower efficacy. Generic medications such as pazopanib and sunitinib offer cost-effective options for treatment advanced renal cell carcinoma. These alternatives ensure care continues despite significant limitations. Now, let's see how these approaches are applied in practice. Here we focus on a 58-year-old male diagnosed with metastatic renal cell carcinoma classified as intermediate risk. Due to financial constraints, immunotherapy was not accessible. The treatment plan started with cytoreductive nephrectomy to reduce tumor burden. This was followed by systemic therapy using generic pazopanib, which achieved stable disease for 10 months. Palliative radiotherapy was employed to manage bone pain. The outcomes show a median progression-free survival of 10.8 months, with treatment being well tolerated. This case shows how smart planning can still lead to meaningful results. Let's now discuss strategies to address this gap further. This section introduces a survey highlighting how Argentinian professionals manage genitourinary cancer. By understanding local strategies, we can draw lessons and identify opportunities for improvement. Genitourinary cancer care involves a diverse team, with oncologists leading up and fellows bringing new perspectives. Experienced professionals add valuable expertise. Access to multidisciplinary teams is different for everyone. Some have regular collaboration, while others face challenges. Healthcare providers work in different settings which affect treatment decisions. Better network or teamwork and collaboration are key to improving patient outcomes. Renal cancer treatment faces major challenges, with limited access to adjuvant cell therapy being the biggest obstacle, followed by cost and toxicity concerns. As a result, fewer than half of patients receive adjuvant treatment. For metastatic RCC, most specialists prefer combining immuno-oncology agents with TKIs, while others choose immunotherapy alone. Overcoming these barriers is crucial to improving patient care and outcomes. Renal cancer treatment shows varying access to sequential therapies, with some patients receiving multiple lines of treatment, while others have limited options. For first-line treatment, many specialists use TKIs with immunotherapy, though cost and patient factor limited border use. Treatment decisions are mainly guided by tumor burden, location, and functional status. This increasing use of combination therapy highlights progress, but challenges in ensuring equal access remain. Bladder cancer treatment relies mostly on cisplatin-based chemotherapy, while immunotherapy are less available. Neoadjuvant therapy is commonly used for muscle-invasive disease, though some apply it only occasionally. Biomarkers like PD-L1 and FGFR3 are increasingly used, but not always integrated into practice. These findings highlight the efforts to expand systemic therapies and biomarker-driven strategies while also revealing gaps in access and implementation. Metastatic bladder cancer treatment shows varied options of new therapies. Avelumab is commonly used for maintenance, though access remains a challenge for many. The combination of nivolumab, gemcitabine, and cisplatin is rarely a standard choice, with most using it selectively or facing access limitations. Enfortumab vedotin is used alone with pembrolizumab or both, but a significant number of clinicians do not incorporate it into their practice. This finding highlight the selective use of innovative treatment with access and past patient eligibility shaping decisions. Metastatic hormone-sensitive prostate cancer is mainly treated with ADT combined with ER inhibitor or docetaxel. However, triplet therapy faces major barriers, with cost being the biggest challenge, followed by accessibility and limited local evidence. PSMA PET imaging is used for treatment response in a small group of patients and only for staging, showing its restricted use in practice. This finding highlights cost as a key obstacle to triplet therapy and confirm the limited adoption of advanced imaging like PSMA PET. Prostate cancer management show gaps in access to PRP inhibitors, with most eligible patients not receiving them due to cost, limited testing facilities, and restricted availability. Routine BRCA testing is also uncommon, with the majority of respondents not performing it. Most cases are a diagnosis at stage 2 and 3, while late-stage diagnoses are less frequent, reflecting disparities in early detection. This finding emphasizes the need to improve affordability, infrastructure, and the integrations of advanced diagnosis and treatment options. In testicular cancer care, late-stage diagnosis is limited access to experienced surgeons remain major challenges, underscoring the importance of early detection and specialized care. VIP chemotherapy is the standard first-line treatment used in most patients, but some still faces access issues. Autologous bone marrow transplant is rarely performed, with very few patients receiving it. These findings highlight the need to improve early diagnosis, increase access to standard therapies, and strengthen surgical and transplant resources. In managing genitourinary tumors, most professionals rely on international guidelines like ESMO and NCCN, often combining them with institutional protocols for flexibility in resource-limited settings. The biggest challenge in access to medication, followed by infrastructure limitations and gaps in medical education. This finding highlights the importance of improving treatment availability, enhancing healthcare systems, and advancing medical training. This slide outlines a roadmap to reduce disparity in GU cancer care. It highlights the inequalities in access and outcomes both within and across countries, emphasizing the need to remove barriers and implement global strategies. The goal is to improve survival and quality of life for patients by promoting equity through collaborative efforts. This roadmap underscores the importance of bridging all these gaps to achieve fair and effective cancer care worldwide. The SWOT analysis highlights key factors in managing GU tumors. Strength, including innovative strategies in low-middle-income countries, strong local expertise, and multidisciplinary approaches. Opportunity to focus on developing region-specific guidelines, cost-effective treatments, and global partnerships to share resources. However, challenges like limited access to medicines, treatment disparities, and gaps in research persist. Threats such as dependence of external funding, medical migration, and expensive therapies worsen inequities. This analysis emphasized the need for coordinated efforts to tackle challenges while leveraging existing strengths. To tackle the challenges from the SWOT analysis, 3 key strategies are proposed. The first is to strengthen local capacities by training healthcare providers, building multidisciplinary teams, and funding new uses for existing drugs. The second is to advance global partnerships to advocate for fair drug pricing, collaborate with regulators and address global disparities. And lastly, investing in education and research is essential, focusing on context-specific guidelines and training physicians in adaptive resource-efficient therapies. Research and data play a critical role in sustainable cancer care. Local researchers help identify disparity and guide interventions. For example, Brazil demonstrates the impact of intravesical mitomycin for bladder cancer, while Peru highlighted inequities in nephrectomy access. Globally, publishing local data amplifies low-middle-income countries' representations, as seen in Africa's success in NCCN-adapted guidelines improving prostate cancer outcomes. These efforts underline the importance of using data to inform policy, allocate resources, and improve patient care. In this section, we'll present treatment algorithm, especially tailored to resource-limited settings. By addressing key challenges in bladder cancer management, these strategies aim to balance accessibility and efficacy. For example, let's explore how we can optimize care with available tools and evidence-based approaches. Bladder cancer treatment varies by stage and resource availability. First-line options include widely used therapies like radiotherapy and chemotherapy, combinations such as gemcitabine or taxanes. Second-line treatments like pembrolizumab provide hope for progressive disease. However, advanced approaches like robotic surgery or targeted therapies such as erdafitinib or enfortumab vedotin remain less accessible in many stations. Bridging this gap is essential for equitable care. This algorithm outlines practical steps for managing bladder cancer in low and middle-income countries. For non-muscle invasive cases, TURBT and intravesical therapies like mitomycin or BCG are emphasized. Muscle-invasive cancer requires radical surgery or chemotherapy when feasible. In advanced stages, systemic chemotherapy remains the cornerstone with immunotherapy or supportive care as an alternative based on resource availability. Regular follow-up with cystoscopy or imaging is crucial for monitoring and timely interventions. Prostate cancer treatment accessibility varies by region. Commonly available options include radiotherapy, hormonal therapy like ADT agonists and antagonists, chemotherapy with docetaxel or cabazitaxel, and oral medications such as abiraterone and enzalutamide. Bone-modifying agents like CA-deno also help manage bone complications. However, access to advanced treatments remains difficult. Robotic surgery, neuroandrogen receptor inhibitors like apalutamide and darolutamide, PRP inhibitors, and lutetium-based radiopharmaceuticals are often hard to access in resource-limited settings due to cost and infrastructure challenges. Expanding access to these therapies requires coordinated global efforts. This algorithm provides a practical framework for managing prostate cancer in resource-limited settings. For localized disease, options include active surveillance, radical prostatectomy, or radiotherapy when available. Locally advanced cases may require IDT with radiotherapy and palliative care when necessary. For metastatic disease, systemic therapy with ADT and ER inhibitor is emphasized, along with palliative care for bone metastasis. The pathways also highlight the importance of supportive care to improve quality of life for patients. Renal cell carcinoma Renal cell carcinoma treatment accessibility varies widely across regions. Commonly available options include sunitinib and pazopanib, widely used as first-line therapies. Other accessible treatments include cabozantinib, everolimus, and nivolumab, which are established options for advanced stage or second-line use. However, newer and innovative therapies face accessibility challenges. For example, adjuvant pembrolizumab is restricted by cost or strict criteria. Combinations like pembro-axi and nivo-ipi, while highly effective, are not universally accessible. Similarly, combinations such as nivo-cabo and pembrolizumab face regulatory and economic barriers. Efforts are needed to improve the global reach of these advanced treatments. This slide presents an algorithm tailored to manage renal cancer. Diagnosis relies on clinical evaluation, imaging like ultrasound or CT, and essential lab tests, with biopsies reserved for advanced or uncertain cases. For localized disease, radical or partial nephrectomy is recommended, with surveillance for smaller tumors under 4 centimeters. Locally advanced cases prioritize radical nephrectomy and adjuvant therapy with accessible. For metastatic disease, systemic therapy, including immunotherapy and VEGF TKIs like sunitinib and pazopanib, plays a central role. Palliative care addresses symptoms, pain, and psychological support, ensuring a focus on quality of life. Treatment for germ cell tumors involves a range of effective options. Surgery, radiotherapy, and the chemotherapy regimen with bleomycin, etoposide, and cisplatin are widely accessible from the foundation of treatment. For cases requiring alternatives, TIP with paclitaxel, ifosfamide, cisplatin, or VIP with vinblastine, ifosfamide, and cisplatin, and GMOX with gemcitabine and oxaliplatin are commonly used and available. Advanced treatment like autologous stem transplantation are typically available at referral centers for patients with relapsed or resistant tumors. Additionally, sperm cryopreservation is crucial supporting measures offered as specialist centers, helping preserve fertility for future planning. This algorithm outlines a practical approach to managing testicular cancer. Diagnosis starts with clinical evaluation, often prompted by a painless testicular mass, supported by scrotal ultrasound, tumor markers, and imaging if available. For local stage, treatment includes radical inguinal orchiectomy with surveillance for low-risk patients and adjuvant chemotherapy with 1 to 2 cycles of BAP for high-risk cases. Advanced disease is treated with chemotherapy, 3 to 4 cycles of BP or EP if bleomycin is unavailable, followed by resection of residual mycis. In relapsed or refractory disease, second-line chemotherapy with TIP or BIP is used and is only if feasible. High-dose chemotherapy with stem cell transplant or surgery for residual tumors. Finally, palliative care addresses pain management, psychological support, and fertility preservation, such as sperm banking where possible. Finally, I will summarize the key points. Risk stratification is central to guiding treatment decisions in renal cell carcinoma, supported by tools like the IMDC score. For advanced urothelial carcinoma, biomarkers such as PD-L1 help optimize systemic therapy. Effective treatment planning relies on multidisciplinary collaboration, combining insights from oncologists, radiologists, urologists, and pathologists to ensure comprehensive care. And finally, cost-effective adjustment, like using generic drugs, balance efficacy with affordability, making advanced therapies more accessible. 3 pillars guide care in low-resource settings. First, adapting to constraints by innovating with local resources and leveraging generic drugs and regional collaborations. Second, equity in care demands systemic improvement, particularly in access to medications, diagnostic, and education. Lastly, a multidisciplinary approach ensures personalized care when and even in challenging circumstances, optimizing patient outcome through teamwork and shared expertise. In low-resource settings, we need to focus on 4 key strategies. First, advocating for equity is essential to address disparities and ensure access to GU cancer care for all patients. Second, being resourceful means adapting treatment using available resources like generic surgery and radiotherapy. And third, strengthening collaboration with regional networks helps to optimize local strategies and share knowledge. Finally, empowering healthcare providers with training programs enhance decision-making and patient care. These actions work together to overcome resource limitations and improve outcomes in GU oncology. To deepen our understanding and explore innovative approaches, I've included these recommended readings. These publications and initiatives addressing disparities in cancer care and advancing global efforts to bridge gaps in treatment. Key topics include access to novel therapies, diversity in clinical trials, telemedicine, emerging markets, and global initiatives. And finally, to conclude, I'd like to express my gratitude to everyone for their time and engagement. Together, we can transform challenges into opportunities. I believe in that. Leveraging innovative approaches to improve outcomes in genitourinary cancer care. Thank you to the OncoAlert Colloquium and its partners for creating this platform to share insights and foster collaborations. Thank you very much.
Thank you for joining us at the Colloquium. We invite you to join us again on demand on all of the sessions as they are now available to all of the registrants. If you know someone who did not register and they would like to see them, please remind them that they can still register at any time of the Colloquium. Once again, we extend our heartfelt gratitude to our partners at ESCO, ESO, MASC, SIAG, as well as our collaborators. A special thank you to Roche and Pfizer for their support of the OncoAlert Colloquium. Thank you for joining us today, and thank you for being part of the OncoAlert community.